Hi, this is Tim Weber from South Texas College, coming to you with the very last video installment in our course on lifespan development. So this is it today. And our topic is continuing our review of death and dying as the final part of the lifespan. And so let's get a pointer here so that I can indicate to you where I am in the outline, and then we'll get started. Okay, so today we're going to start by taking up the question of attending to the needs of the dying. So care for those who are terminally ill has been shown in some studies to be less in quality in terms of physical and emotional care received by those who are dying as opposed to those who are giving non-terminal type of diagnosis. Now, that might seem strange to you, but think about it. There are a couple reasons why you may see this. For one, it may be thought that, well, there's really nothing we can do to save the person's life, and so we might put aside even physical needs for comfort and not be quite as aware of those. And there may be also a sort of a tendency, those who are caring for the dying, to sort of distance themselves as well. And so, for example, maybe nurses, it's very tempting to simply say, I'm not going to get close with them emotionally because I know they're going to die, my patient is not going to live, and it's really going to hurt a lot more if I have an emotional connection with that person. But you know, really to care well for people, often we do have to be somewhat personally involved with them. And so those are tendencies then that we need to be aware of, and we need to be ready to counteract these natural tendencies that we might have so that those who are dying do get the best physical care and emotional care that's available. Elizabeth Kubler-Ross, back in the 1970s, studied the responses of those who were told that they were dying, and this also turns out to be very similar to the responses of people who are grieving, whether they're grieving for the death of a loved one or the loss of some dream that they might have. So these responses apply in a number of situations. What she observed is often one of the first responses is simply denial. Oh, I can't possibly be dying. Oh, I'm not old enough. Oh, there must be an error with the medical tests and so forth. Very common. She also observed that the person may respond with anger. And so they may be angry at those that they perceived caused them to become ill. They may lash out at family members and blame them. They may be angry at themselves for maybe perception that they didn't take care of themselves well enough. They might be angry at God and blame God for their situation. The anger is often not very rational. They also may engage in bargaining. And so they may say out loud or to others, maybe just to themselves, you know, I'll change, I'll be a better person if I can just live, if you let me live, or, you know, if somehow that person can just come back to me, I'll treat them better, you know. So bargaining, very common. And then she observed the person also may become depressed, may become overwhelmed with sadness and remain in that sad mood for a long period of time. And finally, she observed that at some point, some people may begin to feel a sense of acceptance, that they perceive that their death is something that is acceptable to them in some way, or that loss that the person has had, if they're grieving, maybe is something that, again, they simply need to accept that that's the way it is and move on. Now, when she first came out with these observations, it was thought that these were stages through which the person would move from one to the next, to the next, to the next. But subsequent research found that no, this is not a sequential process. There is no particular order. The person, on receiving the news that they're dying, might begin with even a sense of acceptance, but then they might then shortly thereafter become angry, and they might find themselves later on denying that this could be real. It just can go in any order. And it's also, these are not universal in the sense that not everybody feels all of these things or goes through all these things. Some people, they may simply, get angry and stay angry, and that's the only thing that happens. Some people might just get depressed and stay that way. Others, they might do two of these things, but not three of the others. So we have to recognize that this is all very individual, but these are responses that you're likely to see in somebody who's dying or who's grieving. Now let's move over to the right column and have a look at the needs of those who are dying. And here we turn to the work of Abraham Maslow, who identified basic human needs that show up throughout the lifespan, and yes, even when people know they're dying. And so first of all, we have a need that our physiological needs are met. Our needs for food, water, physical comfort, and yes, the dying also exhibit these needs. They need these things to be taken care of. Then we move to needs for safety and security. So that person who is dying needs the sense that they will not be mistreated. They need to have a sense that they also are safe from maybe being subjected to procedures that don't benefit them. They need to have a sense of safety. They need to have a sense that those who are caring for them really have their best interest in mind. They also continue to have needs for love and acceptance. So those who are dying do need to have the opportunity to express their love towards others that they are close to, and they need to have the opportunity to interact with those they love and have close relationships. And when separated from them, this is often very distressing. And I say that because the time I'm making this, we're in the midst of the COVID pandemic, and we now know that many people who were dying of COVID in intensive care units were unable to directly communicate with their loved ones, and family members were not able to do that as well. And so this was, again, very distressing to them, and distressing again to family members who lost that loved one and couldn't be there to directly express their love for them. So this is very important. The person who's dying also continues to have a need for esteem and respect. And this includes that their wishes to be respected. So if they would prefer not to be revived, should they stop breathing, that is one of those basic human needs, that their wishes be respected. They also continue to have needs for self-actualization. You might remember this is the opportunity to express their full potential. This is, again, So that person who's dying, they may have some project that they wish to finish. Maybe they're writing a book and they want to finish that. Maybe there's some other thing they want to accomplish as well, something that they've always wanted to do or produce. And so, if at all possible, they need the opportunity to achieve this goal that they might have, whatever that goal might be. Okay, now let's move down to the last item on this page, the patient's right to know. So our current medical ethics indicate that patients have a right to know about their diagnosis as well as the prognosis. In other words, if you have a patient who has been diagnosed with a terminal illness and they ask, am I dying? Then we must tell them that. Okay, we must reveal that to them. Now, that may go against what family members might want. Maybe family members do not want that person to be told that they're terminally ill. Here, in addition to the patient's right to know, consider that if we do not allow that person to know their situation, then we may be denying them opportunities to do things that they would want to do in that situation. So if we don't tell that, if we don't reveal that to that patient when they ask that they're terminally ill, we may be, they may have wanted to reconcile and forgive someone that they had an argument with, or they would have wanted to. They might want to say their final goodbyes to family members. If we don't tell them, we've taken that opportunity away from them. So that's something important to remember beyond just the legal requirement that we reveal that to them if they ask that. So let's have a look also then at the use of hospice. So hospice is a situation where the person receives skilled treatment by caregivers. This may be done in the person's home or it may be done in a hospice facility. So the care that is given is generally going to be palliative care. What's that? Palliative care to allow the person to be more comfortable, to relieve pain and suffering. So palliative care is not an attempt to cure that person's illness, but rather to maintain their quality of life. So usually in hospice, curative treatments or life-extending treatments are not given. Now there's exceptions to that, but mostly that's the case. Hospice then is designed to respect the patient's autonomy, their ability to make their own decisions. And so the person is then, their wishes are respected in terms of how they are treated. Good hospice care also involves care and counseling for the family and friends of the person who is dying. So that's something that's often forgotten is these people need care as well. There are many barriers to the use of hospice care that we'll look at here in a moment. The basic, if you will, kind of bottom line with hospice care is this is designed to allow that person to die with dignity. That's one of the main goals. So let's have a look at some barriers. Why don't more people enter hospice care as they're passing away, as they're terminally ill? And first of all, notice that death must be anticipated within 6 months. But those kind of predictions are difficult to make. Physicians are sort of hesitant to predict how long that person may have because often it's not what they might have guessed. So first of all, you have to have uh, a, uh, a physician to actually certify that this person is not going to live more than 6 months. Also, the patient and caregivers must accept that that person is truly dying. And many people avoid hospice because they want to keep hope alive, even if the odds are strongly against them recovering. They may feel that if they just continue to hope and pretend that that person is not dying, that they're going to recover. Um, Now, I will say one thing. I will say that, yeah, uh, there is some truth to that. It is true that, mm, you know, sometimes when people are told that they're dying, they may become depressed, and that affects the functioning of their body. And it's true, they may not live quite as long. Um, but that said, know that, in this case, we're looking at a situation where death is inevitable. Also, hospice care is expensive. Okay, it involves many different people to participate, individualized care day and night, and in cases, in many cases, insurance companies may be limited in terms of what they're going to cover. And so if the person can't afford some of that out-of-pocket expense, then they may not be able to afford it, or may not be able to afford it for a very long period of time. And the availability of the hospice care varies a lot too, depending upon what part of the country or what part of the world you're in. There may be spaces available in hospice facilities. There may be at-home hospice workers available, or there might not be, or not enough. So these are some of the reasons that people who maybe would use it may not in some cases. Just to back up, I wanted to mention that when it comes to palliative care, whether this is in a hospital setting, at home, or hospice, palliative care, one of the concerns about relieving people's pain is sometimes the amount of medication that is needed to maintain that person's quality of life might bring about their death somewhat earlier. And so some have concerns about that. So again, we have to weigh uh, the person's quality of life against the amount of time that they may live. I think now there is more of a movement amongst doctors to manage people's pain effectively. And so that's improving. For years ago, there was concern even that the person terminally ill might become addicted to the medication, which kind of doesn't make sense. If they're terminally ill, we're not going to worry about that. So, but do be aware that sometimes it is a decision: do we relieve that person's pain and suffering, or do we let them feel that, suffer, in order to simply have them living somewhat longer? Okay, and now we get to some of the things that really get kind of confusing. And that's the question, when is a person dead? Now, this used to be really easy. So, years ago, well, if a person's heart stopped, they're dead. If they stop breathing, they're dead, because there was little you could do to revive them, or at least it was thought, years and years and years ago. Um, okay, well, it's not so easy now, because, in fact, we may be able to resuscitate them. However, well, have a look at this, dead or not. Yes, no, maybe. Okay, so here's a number of scenarios. Brain death. Brain activity has ceased, all brain activity. for a prolonged period of time, complete absence of voluntary movements, no spontaneous breathing, person does not respond to pain, noise, or any other stimuli, no brain waves, EEG is flat. Is the person alive? After a prolonged cessation of brain activity such as this, we have to assume person is dead, okay? Because there is no brain functioning for a significant period of time. Now, here's one that's locked-in syndrome. Person can't move, but brain waves are still apparent. Is person dead? No. If there are brain waves, then there's a potential that that person may be aware. Okay, so scary thing to think of though, isn't it? Okay, coma. Here, the person is deeply unconscious and we are unable to arouse them from that unconsciousness. So what's the situation here? Well, some people spontaneously come out of that coma while others enter a vegetative state, but at this point, we can't tell. We have to assume person is not dead, okay? Because notice, yes, some people will come out of that coma. All right, our fourth one, person is in a vegetative state. Here we have deep unconsciousness, all cognitive functions, thinking, so forth, intentional behavior, all presumably absent. So it seems that there is no awareness. Eyes may be open, or they may open, even if they're closed, had been closed. Sounds may be emitted. Breathing may continue on its own. Is the person dead? We have to say the person is not yet dead when they first enter this vegetative state. Okay, now here's the thing. No one's ever recovered from a vegetative state after being in that state for more than 2 years. And those who do come out of that vegetative state, which is about 15% of those who go into this vegetative state, they will improve within 3 weeks. So if they're going to recover, almost all the time, you will see improvement in a short period of time. Where there is not improvement as the time goes longer and longer, the less likely they are going to come out of that vegetative state as more and more time passes. So we can say that as time passes, the longer this has occurred, the more likely that that person is no longer really with us. Okay, now there's the question, how long? Okay, yeah. And so that becomes a difficult question for family members who have to make decisions as to whether life-sustaining treatments might be continued or not, whether assistance to respiration, so on, continue, and so forth. That becomes a very difficult decision. But again, one of the things that can help guide that decision is that the longer this has been going on, the more likely it is to be permanent rather than transient. Okay. So let's take up a couple other concepts. For some reason. So here we have passive euthanasia. Now, the word euthanasia literally means good death. So passive euthanasia is what? Allowing the patient to die naturally, letting nature take its course. So life-sustaining medical intervention is discontinued. Let nature take its course. Now, a lot of people are not going to have too much problem with that. because it seems like, well, this is the natural course of things. In fact, with regard to that, the patient or a healthcare proxy can request that the doctor provide a do not resuscitate order. And this is written on the person's chart, so forth, so that if they suffer cardiac or respiratory arrest, medical personnel know not to try to revive them. So again, this is, if you will, let nature take its course. So mostly people are okay with that if there is not much likelihood the person is going to recover. Okay. On the other hand, we have active euthanasia. In this case, this is where someone takes an action that is intended to bring about that person's death, even if it would not naturally occur at that point in time. So usually when this is done, the reason given is this is to end the person's suffering or to comply with their wishes to pass away. So this may be done legally in some states, in some countries, in the form of physician-assisted suicide. That's a form of active euthanasia. In this case, the doctor is providing that patient a way that they can then use to end their life. So physician-assisted suicide has been legalized in several countries. It's legal in 9 U.S. states, as well as the District of Columbia here in the U.S. So to give you some idea of how this is regulated, this is the way that it's done in the state of Oregon, which I think was the first in the U.S. to legalize this. First of all, only residents of that state can request this. Their request has to be submitted twice orally and once in writing. There has to be 15 days minimum between their first request and the doctor issuing a prescription. And 2 doctors must confirm that that person is not going to live more than 6 months and that that person is not mentally impaired or depressed. Okay, so there are a number of, you might say, safeguards here. Of those who apply for physician-assisted suicide in this state, about 1/3 of the applicants' applications are approved. Interestingly, 1/3 of those who are approved never use the drugs that are prescribed the patient. So it seems that some people wanted to simply have this option to end their life if they choose at some point. So this is then something that, of course, becomes quite controversial. Does the person have the right to take their own life? And often this ties in with various religious beliefs as well. There's also concern about physician suicide in a couple other counts. One is in terms of physicians. Physician takes an oath to do no harm. And so some would say, well, this is doing something that is harmful to the patient. They're doing something that is not curative, but is actually harming their physical health. Another concern is, even if this might be legal, might be acceptable, that this might also be something that is sort of on a slippery slope. And so if it's okay for the person to end their own life medically, some fear that maybe this is going to also evolve into maybe doctors making the decision that this person should live or should not live and so forth. So a lot of concern about that. And so I think this is one of these issues that one has to really, really pin down just what are your beliefs, what are your values, just how do you see these things, and look at it from that particular perspective as well as any facts that exist. Okay, so we'll leave it there. Okay, Just a bit about advanced directives in terms of care if a person is incapacitated. So some people will make a living will that specifies what medical intervention is desired if they are incapacitated and unable to make medical decisions. So that's going to list that when this is done, it's important that very specific language is used, because even terms like incurable or having a reasonable chance of recovery can have a very broad interpretation. We say you have an incurable illness. Well, yeah, certain kinds of illnesses may not be curable, but you might be able to live with them and have a very good quality of life for many, many years with that particular illness, right? Or what about reasonable chance of recovery? The person says, well, I don't want this done if I have a reasonable chance of recovery. Well, what do we mean? Do we mean, a 90% chance of recovery, 50%, 15%, 5%? And can we even really even estimate what the person's chance of recovering is? So it's very important to use very specific language about what the person actually wants done or not done. Another type of advanced directive would be to designate a healthcare proxy, or sometimes they refer to this as medical power of attorney. So this is the person designates someone to make the decisions for them if they should become incapacitated, unconscious, able to make their own decisions. Now, what's really important here is that communication, okay? Clear communication in terms of the living will or healthcare proxy, okay? Just to give you an idea, my mom's 88 years old, and she's designated me as her healthcare proxy, medical power of attorney. So if she's incapacitated, I'm going to have to make any medical decisions that might be needed. So I said to Mom, well, let's talk about this. What if this happens? Would you want this to be done? Would you want that to be done? Well, guess what? Her response is, well, when the right time comes, I know you'll make the right decisions. So, and then change the subject. Yeah, notice, boy, that puts you in pretty precarious situation. You don't really know for sure what she would have decided. You want to do what she would have decided, but you haven't really been able to have that discussion. So I want to say, yeah, when people are designated for this, let's try to make sure that they do have a good discussion about what the person's desires actually are. Now, when it comes to living wills, healthcare proxies, only 25% of Americans have both of these. That actually surprised me that there's that many. But majority of people do not. So what happens if medical decisions need to be made and they're not able to do that for themselves? Well, here's something to think about. This is a case from some years ago. This young woman named Terry Schiavo, she had a situation where she lost consciousness, eventually ended up in a vegetative state. She was in her 20s when this happened, and there were no advance directives. And so there were questions as to whether certain treatments should be continued. There were family disputes as a result. There were no solid legal definitions that could guide those decisions. And there were differing values between her husband, who actually eventually had divorced and married someone else, but who later on wanted to intervene and help make those decisions, or actually make the decision. So there was this argument between family members and this ex-husband. And so who had the legal right to make the decisions? And so at one point, her being in a vegetative state all this time, a feeding tube was inserted, and then the feeding tube was removed for a time, and then it was again reinserted. And can you imagine how distressful that would be for family members and so on? So I guess the bottom line is maybe it's a good idea that all of us do this so that whatever we would wish happen, case of being incapacitated, that can be observed, even if we're young, like she was when this all started. Now, every semester when we talk about this, I say to the class, you know what? I'm one of those persons that needs to get this done. And I just happen to be 63 years old. And so as soon as the semester is over, I have a little time, I'm going to get this done. But you know what? Every semester goes by, I still don't do it. I met one of my former students in the grocery store a little while ago. And you know what they said to me? Hey, did you ever do that living will like you were talking about? And I said, no, I didn't do it. So yeah, we may hesitate to do it, but maybe we should think about that. And so now I'm telling myself I need to get busy and do it. Okay, now let's go on to the topic of bereavement and grief. So when we look at this, bereavement is the emotional sense of loss people feel following the death of a loved one. So this is the emotional part of it. Grief, then powerful sorrow, emotional responses to that person's death. When people are grieving, they may experience bouts of crying, trouble sleeping. They may have irrational thoughts that don't make sense, maybe even delusional thoughts. It's not unusual for people who are grieving to momentarily hear that person's voice for a moment or think that they just saw them around the corner. That's not unusual, okay? This is often a part of that grieving. And when people are grieving, they may have difficulty functioning normally as well. They may not be able to take care of their personal care of themselves and others or their work as readily as before, maybe not at all from some periods of time. When we talk about mourning, this is also part of bereavement. And mourning involves the public and ritualistic expressions of bereavement. So the ceremonies, rituals, and behavior that are observed as part of that person's religion or as part of their culture for the person who is bereaved. So, you know, funerals, rosaries, doing things like wearing black or covering up mirrors, not watching TV or whatever it is that that person's religion or culture prescribed. It's sort of the outward indication that that person is mourning, is grieving. And these rituals and observances actually may be very beneficial. The bereaved may be very vulnerable in terms of their mental and physical health. Yeah, there are studies that show people are more likely to even more likely to die or have accidents and so on after the death of a loved one, more so than ordinarily. The bereaved also may be more vulnerable to engaging in self-destructive behavior, reckless behavior, um, you know, drug abuse, you know, that kind of thing as well, or even not eating. And so these, again, rituals and observances can play a role in helping to prevent self-destructive behavior. Because one of the things that these do is these tend to put the person in touch with others who can express concern for them, who can help comfort them. And that's the value of these rituals and these prescribed behaviors. Now, just to give you an example, in Jewish culture, there is this practice of Shiva after a loved one dies, and the person, a number of observances are done. Part of that is that others then are to come to their home and comfort them, spend time with them. Part of that also is a comfort meal, which is usually very shortly after that person, the deceased, is buried. So notice how this puts the person in touch with others who can help them deal with the grief that they're experiencing, help them process and talk about it, and that comfort meal in order to make sure that they're actually getting physical sustenance, because often people will engage in the self-destructive behavior of not eating properly. So this is observed for the first week after the deceased person is buried. Notice how that can be beneficial. So many of these rituals, whatever the religious background or cultural background, put that person in touch with others for comfort and for safety. So these assist the bereaved in by providing support from others, and also help the person to come to acceptance of that person's death, and may help reaffirm the value of that person's life. So may remind them of how important that person was to them. Now, when people are bereaved, often they will seek blame or they'll seek meaning in their bereavement. So a common impulse after the death of a loved one for survivors is to blame. And so they may blame the medical personnel. They may feel that they made mistakes. They might blame the person who died. They didn't take care of themselves like they should have. They might blame themselves. Oh, I didn't watch out for their needs like I should have. They might blame God. You name it. It doesn't have to be rational. It seems even blame may be completely irrational. And so grief is intense and irrational at first, but gradually this eases over time, and they begin to see things more in perspective. Also, we find that people may look at this as a time to find meaning in that person's death by remembering the person who is deceased and just what things were important that they contributed to their lives or that of others. So as people do this, time, support from others, social support, and engaging in traditions that might be comforting can help that person to, again, come to an acceptance of that person's death. It's also notable that sometimes those who mourn are actually spurred to action. Think of Mad Mothers Against Drunk Drivers. Their sons or daughters were killed by drunk drivers. And so do you think they were angry? Of course. But they're not just leaving it at that. They are now going to try to prevent that from happening to others. And so they've been spurred to action. Or think about also some of the protests that have occurred where family members of people who have died a wrongful death now are urging that these wrongful deaths do not occur anymore, that things are changed in order to prevent that in the future. So we can also identify a number of types of what we'll call complicated grief. And so this is where the person's grieving process is interfered with by any number of things. So in general, this occurs more often today because people engage in public rituals, observances less frequently than they did in the past. Whereas almost always in the past, people would have funerals and so on. Sometimes now they don't. Or this may occur where there's a lack of time to slow down and actually consider what has happened. Social isolation may contribute to this as well. The person is not in touch with others, and so there aren't others to discuss this with. Impersonal nature of today's society, so others may not really connect with them because, well, they don't want to interfere, they don't want to bring it up, and so forth. So there's a number of things that today this has become actually probably somewhat more common. So one form of this, you might call it absent grief. Grief person doesn't seem to mourn at all. They seem to be completely unaffected. Now, you might look at that and say, oh, the person seems to be taking it very well. But notice they're not really processing what has happened. And at some point, they've got to process this. So if they continue in this absent grief sort of state, somewhere inside of them, there is still a need to deal with that person's death. And if they don't attend to this, if they don't have an opportunity to grieve, then this can actually result in physical or psychological harm. The person, due to the psychic stress of it, if you will, may develop physical ailments having not dealt with it, or psychological disorders as a result. So we need to give people the opportunity to grieve so that this doesn't happen. We need to tell them it's okay. It's okay to mourn. It's okay to express yourself about it. Okay. There's also what we call disenfranchised grief. And here, certain people not allowed to mourn publicly. Again, this interferes with them being able to process the whole thing. So, for example, we might have, maybe you have a homosexual couple and one of the partners dies, but the surviving partner feels uncomfortable even attending the funeral because they have not been accepted by their partner's family members. And so they feel they haven't had the opportunity to say their final goodbye to that person. They've been deprived of that. Or think about the situation, maybe there is a person whose ex-husband or wife dies, and that person did mean something important to them, but yet they're not allowed to, they don't feel comfortable going to that funeral. Again, they may feel that they should have done that, but they couldn't. And so they're kind of blocked in processing their grief about the whole thing. We also have situations where we might call it incomplete grief. So there are circumstances that interfere with that process of grieving. Now, it might be simply that, hey, they have to move right on without any opportunity to stop and process it. This might happen, for example, in a situation where we have soldiers deployed in a combat zone, and one of the fellow soldiers is killed in action, but yet they have to go right back out on patrol, and they don't have a chance to spend much time actually observing that person's death. Or how about this? The person dies in a homicide, a murder, let's say, okay? And then, so they have to participate in the police investigation. Police have to interview family members. There has to be an autopsy, which delays that person's funeral. And so, again, they're not able to really move through that grieving process because of these interruptions. They can't put the person to rest yet. Or how about a situation where there is no body to bury? A person disappears, never found again. Yeah, can you imagine how distressful that is? Because you never can really put an end to it. Okay, so notice that people who experience these roadblocks to grieving can be aided by others. So we have to keep that in mind. They may need some particular help in dealing with their grief. So when people grieve, then we see a wide diversity of reactions. Bereaved people depend often on customs and attitudes of their culture to guide them, but even so, it's a very individualistic process. So let's finish up with a little bit of grief research and then how we can be of service to the bereaved. So here's some research back from 2004, 2005. It's still really pertinent. What Berner and others found in their research is it's very common for people to idealize the deceased person, to remember all of their good qualities and maybe even remember them as being better than they actually were, but at the same time, sort of ignoring maybe some of their negative qualities as well. Sort of looking at the person through rose-colored glasses, as they say. Thinking of the deceased, they found was more frequent at first after the person's death, but as time went on, people thought less often of them. In terms of how people then coped with the death of a loved one, they found that 50% of people returned to their previous levels of happiness and productivity in 6 months. So that's encouraging. On the other hand, 11% of people experience increased levels of depression for 6 months, but even this seemed to taper off gradually by 18 months. They interestingly found that 18% of people who lost a loved one actually were less depressed after that person's death than before. Now, in many cases, this can be accounted for where you have, say, family caregivers that were caring for that dying person. They saw them suffering, and now they felt relieved that that person was no longer suffering. And so that's one scenario. The other scenario that's common with that is the person was an abusive individual, and now this person was no longer abusing those survivors. So that might surprise you, though, 18% less depressed. They found 11% of people were slow to regain their functioning. They were still functioning poorly at 18 months, but even then, most were functioning better by the time 4 years had elapsed. So eventually, even those who did the worst improved. So in terms of how we can be of service to those who are grieving, the social support we can provide can be just golden to them. So when we're dealing with them, we often, and I guess I should say, a lot of times people are hesitant to be around those who are grieving. You say, well, why don't you go and spend some time with them? And what are people's fears about that? Oh, I wouldn't know what to say. I wouldn't know what to do. Maybe I'll say something wrong. And I think that's normal to feel that way. But notice the good news is you don't have to know what to do or say, because one of the most important things is simply to be there with them and to listen, to empathize. Yeah. So, notice that that's really beneficial. Often what they want is just someone to hear them. And as we do this, we should be careful not to judge them, not to say, oh, you shouldn't feel that way. Let their feelings be their feelings. We should also be careful not to ignore the pain that they're experiencing. That pain is real. It's real to them. And so we should acknowledge, yeah, I can see you're hurting. Yeah. We should also recognize that emotions that occur as people grieve can be very complex. They may be angry one minute and at the same time sad that person died. They might be angry that that person has died and left them, and at the same time sad the person is not there. You just name it, all kinds of confusing emotions are swirling around, and know that that's normal. And it may not make sense. It may not make sense. We should also realize that how people respond to loss is a very individual thing. Just to give you an example, my dad passed away 20 years ago now, and it affected me and my youngest brother in a very different way. My youngest brother, it just knocked the wind out of him, and he literally had trouble focusing on work and so on for the next 3-4 months. But after that time passed, it seemed that, well, he sort of was able to put it behind him, and away he went, and he was fine. Seemed to be done with that whole grieving process. Me, on the other hand, different, because when he passed away, it didn't seem to affect me all that much. And in fact, I kind of wondered if I was okay. But what I found is, rather than taking a big hit all at once, dealing with that grief, I process it a little at a time. And so, not all at one time, maybe just now and then. I think about it, I'm out hunting and it's quiet and I'm thinking, and I'll think about my dad and I'll sort of, process that a bit. And then maybe I don't think about it for some while. And then again, and so, yeah, it's very individual. Everybody's different. We should also take cultural norms into consideration. There are cultural groups where it's prescribed that you mourn for that person for a few days and then you're done and you don't mourn anymore. Okay. And you look at that and you go, oh, they're so cold-hearted. No, that's just their cultural norm. So take that into consideration. Be aware that grieving can be a long process. Not everybody just knocks that whole thing out, comes to a sense of acceptance in a few days. Be also aware that sharing emotions soothes. So encourage that person to share their emotions. Tell them it's okay. It's okay to express those emotions. It's good. And know that honoring and remembering the deceased can be healing. So if that person wants to go to the cemetery, put flowers on the grave, if they want to get out pictures of the deceased, tell stories about them, go along with them. Listen to them, because that's healing. As they remember that person, they're processing that. They're coming to terms with it. And be aware also that recovery from that loss never happens. The person is never going to be exactly the same as they were before. Now, that doesn't mean that they're going to be worse off than before. No, in fact, there can be many beneficial things that come out of that grieving process. The person comes to an acceptance of that person's death, and they may find actually new meaning in life as they consider what that person had contributed and how they might now contribute as well. They might find that they have new insights into life that they did not have before. And for some, this may be even a time of transformation and maybe a time of personal growth as they consider what that person's life and death meant to them. So just remember, they're not going to be the same, but there is potential that they are actually going to be better in some of these ways. So I want to kind of close this off then with some quotes from Berger's textbook. I thought they were very good and expressed things far better than I could. So I'll just read them to you and let you maybe have a moment to think about them. So she says, the process of living is an art as well as a science, with strands of love, sorrow woven into each person's unique tapestry. Grief, when it's allowed expression, mourning, when it fosters reaffirmation, all give added meaning to birth, growth, development, and human relationships. So I want to thank you for listening. I want to pray blessings to all of you. Love you all. And so here you are at the end of the course. So take care.